last presentation, which is on issues, which is just a potpourri of subjects which I sort of put together. No, they don't go in a correct sequence, but I thought they may be important in the overall perspective of ROP management. Can one miss identifying ROP? I can assure you, because even I missed. So, inexperienced examiner, of course, more easy to miss. Not that experienced examiners cannot miss. A rushed examination, maybe because you are seeing too many patients in a given day, or you're rushed to go from place to place, or less than optimum conditions for examination, like a bright lily 10 ICU is not the best place to examine for ROP. So you should have the guts to tell the nurse to switch off the lights, at least in the area where you're examining the baby. An improperly positioned crib, so you try to maneuver yourself between the two cribs and try to examine the baby rather than trying to push the baby to a particular location where you're comfortably examining. There are tubes all around the infant. It doesn't matter. You should tend to ignore all the intricacies, the tubes around the baby, but try to examine very carefully the eyeball. A very unstable infant where there is a pressure by the neonatologist that your examination should be very brief. Obviously, you would like to have the most experienced examiner examining, and that's it. Not allow the trainee examiners to examine this particular baby. Inadequately dilating pupils is a challenge. Then, of course, you can slightly indent pupil dilate a little bit. Use a 30 diopter lens. You can still manage to get some idea as to what is happening. And sometimes a red cam can actually be more useful in a relatively non-dilating pupil compared to indirect ophthalmoscopy under these difficult situations. But of course, in those cases, you re-examine the baby after day or two and not after next week by using some steroid drops so the pupil will dilate better. The safeguard against missing ROP is final examination clearance is given always by an experienced examiner. If the first examination is done by a trainee resident, then once you clear the case as having no ROP only by an experienced examiner and not by just a teleconsultation alone. It's always done with indirect ophthalmoscopy with indentation before you clear it as no ROP. Okay, so dilatation for ROP eye examination. Studies have shown that the significant blood levels of cyclopentolate in the blood can be associated with gastric residuals, and that can have create problems for neonatologists in terms of aspiration, etc. So there are alternative dilation methods which are not as yet available, but perhaps something which we can keep in mind or even promote this idea with the pharmacy or with the industry to allow us to have specific products for ROP dilation, such as Midiacet, lower conjunctival fornix packing, micro drops where the amount of medicine you put in the eye is minimized, so the systemic absorption and toxic effects are correspondingly reduced, and a diligence with punctal occlusion, because very often you order dilation, the neonatal nurse will put the drops. She's not bothered about using punctal occlusion and all that. She just puts the drops and then calls you after half an hour. So that is where probably there is importance for us to train the neonatal nurse that there is importance in occluding the puncta. There is also the problem of inter-observer variation in the interpretation. Just to highlight the problem, the study by Campbell in 2016 of 1,553 eyes comparing PIO with REDCAM image evaluation showed there is a 40% disagreement in the staging classification, 18% disagreement in the plus disease classification, and 8% disagreement in zonal distribution, which is zone 2 or zone 1. So 40% disagreement in the overall staging. So this is a huge amount of discrepancy between two observers in terms of what it is. So this is even more relevant when talking of tele-interpretation of the images, wherein this problem can be very, very important. Likewise, in a study by Fleck et al., they have shown as part of a BOOST trial that the treatment requiring ROP was more often diagnosed by the British ophthalmologists versus New Zealand. The same pictures seen by the two groups. And plus disease again was more often diagnosed by the British ophthalmologists compared to New Zealand. So this tells you that there can be difference of opinion when you're interpreting the same eye or examining the same eye even with the BIO. This particular chart gives you some guidelines as to labeling what is zone 1 versus zone 2. Because zone 1 versus zone 2, not just talking in terms of clock hours or from the macula, but in terms of characteristics which can define zone 1 ROP. This is in zone 1, the disease obviously is in the posterior pole. In zone 2, it's outside the posterior pole, that we know. But how do we know in a given eye, is it restricted to the posterior pole or not? We're not going to sit there and measure, draw circles on the eye. So zone 1 ROP is always 360 degrees, that is 12 clock hours, while zone 2 can be variable. Normal arcades are almost absent in zone 1 ROP versus zone 2 ROP. A ridge is present in zone 2, but very often is absent in zone 1 ROP, where you find dilated vessels with in between no capillary seen. A wedge is never present in zone 1 ROP, while in zone 2 you can have a wedge at the temporal horizontal meridian. Regression probably doesn't occur spontaneously in zone 1, but with treatment it can, while in zone 2 spontaneous regression can happen. So there is a poor overall unfavorable outcome in zone 1 versus zone 2. So considering all the factors together, one can define what is zone 1 versus zone 2 and then indicate the indication for anti-VEGF treatment. There is also the plus disease conundrum. ICROP3 third edition, in which Dr. Vinekar was a part of this team, have defined that the plus disease is a continuous spectrum. But they left it at that. But the definition of still type 1 and type 2 ROP is based upon labeling it as plus or no plus, not as a part of the continuous spectrum. So you are still left with defining it as is there plus or not, so that I can treat the patient. If there's no plus, you probably can observe. There's also no guideline as to what to do if you label it as pre-plus. Would you treat or would you not treat? So these are situations where you have to use your own intuitive indication as to treat or observe. So the practical suggestions are, if pre-plus is diagnosed and the diagnosis of plus is still doubtful, perhaps it's best to have one more opinion from your colleague and tilt towards the plus if the fellow eye has a frank plus. Treat it as a plus if the child is likely to go for any surgical intervention for systemic indications, as I just now indicated, and shorten the interval between examinations to facilitate better conclusions. The APROP, the confusion of the diagnosis, because APROP is characterized by flat neovascularization. This can be zone 1, but it can also be posterior zone 2. It need not be only a zone 1 disease. So peripheral or mid-peripheral APROP also has been described now. It is characterized by severe plus disease, large vascular loops, and retinal, vascular, and vitreous hemorrhages, which is a characteristic. Usually affects extremely premature babies, but often more sick babies and also with unmonitored oxygen treatment. There are hybrid varieties described. Dr. Mangadram Doctor was first to describe these hybrid diseases. Varieties have components of both the degree of classic component versus the APROP component. The hybrid varieties obviously have better prognosis because parts of the retina is behaving like a classic ROP. They are described in heavier babies and have been described with zone 2. Extreme forms pose no difficulty in diagnosis, but this is a publication from the LSHTM course on ROP, which tends to give you two pictures which can be similar but different. One was APROP, the other is a classical ROP stage 3 plus. You can see the typical ridge in the temporal periphery in the picture to your right. So that tells you that it's a classic ROP and not an APROP. Now, treating 6 o'clock and 12 o'clock meridians with laser could be very tricky, and very often people have missed treating that area and was the cause for a recurrence in that area. So it's easy to miss this area unless you continuously go from one meridian to the next meridian and not jump from one area to another area. So ideal is to position yourself diametrically opposite the meridian you're treating. If it's 12 o'clock, it is 6 o'clock you stand. If it is 6 o'clock, it's 12 o'clock you stand. You can rotate the baby around so that you don't have to move, but the baby keeps rotating, and then you treat. In a non-dilating people, you can use a 30 diopter lens and produce at least some burns posteriorly very close to the ridge so that you get a better chance to treat once the people start dilating, as you've already treated some areas. And treat posteriorly as much as possible because that is the area which liberates maximum VEGF. The area of avascular retina very close to the ridge is what secretes maximum VEGF. So you treat there. In the worst case, you can always treat with topical steroid or anti-VEGF and then treat subsequently. Follow up post-injection of anti-VEGF. How frequently does one follow up these children? If no recurrence, but there's persistent avascularization, now what to do? When do we decide on laser to avascularization? Some of these have been already answered. I'm sure you have a lot of questions about this, but I don't think time permits us to discuss about each one of them in detail. Now, is there any role of buckle in stage 4 and 5 ROP? In stage 5 ROP, perhaps there's really no role, except if it's mostly exudative RD with a little bit of peripheral fibrosis, then you can still try band and a drainage. I have done in one case where I just put a band and a drainage and actually did extremely well. It was stage 5 in the sense it's a total RD and macula is involved, but in the sense that entire RD is not fibrotic and tractional. Part of it is actually exudative and periphery is actually having fibrotic disease, and hence it worked well with just a buckle, no vitrectomy. Does one operate on eyes with fully formed falciform fold with retinoretinal synechae? I would think as long as if the retina is stuck from the anterior to all the way to the RPE, there's no way you can really open it. There's no meaning in operating on such eyes, especially these eyes coming after 1 year of age. There's no meaning in operating. But if it's like a tent, there's still a possibility that if you can relieve traction, you can reduce at least the amount of retina that is caught up in the retinoretinal synechae and give them a little better vision. If a break forms during vitreoretinal surgery for ROP, is there a role of tamponading? Yes and no. If you create a break in an eye where you only relieved about 30% of traction, there's really not much you can do about it. Perhaps it's best you close the eye and go home rather than prolonging the anesthesia for no reason. But if you relieved most of the traction and you have created a break, sometimes you can get away with removing all traction and even putting a tamponading agent. I've had good success with silicone oil tamponading agent only in stage 4B eyes wherein periphery has been well treated and is fibrotic, and while dissecting it created a break, then you remove the entire traction, put in silicone oil. They do quite well. But full-blown stage 5 ROPs with tractional RD with a closed funnel configuration, you very often don't do well with any tamponading agent. Thank you for your attention.